I'm going to be reviewing this module with you that mirrors together the classification of nerve injury with an understanding of how to interpret electrodiagnostic studies. And I'd add to my disclosures by saying that I've learned so much from Doctors Buccelli and Alozzi, who are the neurologists that I work with in the clinic. There's also a superior textbook by Preston and Shapiro, and we'll give you the reference to that at the conclusion of this. I'm going to try to go through this with you, but I would imagine that you would eventually want to dig into it and start and stop and review things. But I'm excited to discuss this with you. Andrew and I have spent a lot of time putting this together. So here we go. Always start with the classification. Over on the far left, you can see the classifications that we're familiar with. Seddon's classification, Sunderland's classification. But take a look at that classification that's colored. This is what surgeons want to know, and especially patients want to know. Will my injury get better? And will it get better fast or slow? Or am I in the unfavorable group where it's not going to get better? So I would suggest that maybe going forward in the future, we could be kind to ourselves and just start to really understand that those are the injury classifications: favorable fast, favorable slow, unfavorable, and then that middle group, the Axonotmetic 3 group, where it's partial recovery, and it can be very variable, and it's definitely slow. Okay, now look over on the right-hand side where it says Electrodiagnostic Studies. We're going to be talking in this module about acute nerve injuries and what happens after an acute nerve injury and how it moves from acute to chronic. We're going to be talking about the electrodiagnostic study with the two parts, the EMG and the nerve conduction studies. But take a look here, and if you look at the fibrillations and the positive sharp waves and then the motor unit potentials. With an acute nerve injury, if you see fibrillations, it means you have an axonal nerve fiber damage. By contrast, if you don't and you have a palsy, that is a good prognosis for neuropraxia. It's just a myelinating problem. Now, when you look at the motor unit potentials, if you see motor unit potentials coming back into that muscle that's been injured at around 3 months, that suggests a favorable injury, which would be an axonal 2 and slow but great recovery. If you see motor units not appear until 4 months or later, but do appear, then that gives you this variable partial recovery, which can go all the way from really good to really bad. And then, of course, if there are no motor units present at 4 months, then it's highly likely you're going to have a 4th degree injury, either in continuity or in 2 pieces, and you're going to have to move forward with respect to surgery. With respect to the rate of recovery, we're very familiar with this concept, but I'd like to emphasize that the rate of recovery at an inch a month, a millimeter a day, a foot a year is for the pioneer axons to reach target. It's not for your patient to have MRC grade 3 recovery of muscle function. It's just get to target. So I think that's important to also emphasize to your patients who will get a tape measure out, measure the distance, and expect recovery. Let's just take a look at this concept of the myelin with the neuropraxia and ischemia injuries with neuropraxia and axonal injuries in the situation of a compression neuropathy after surgical recovery. So with compression, we can see ischemia or demyelination, but if it's ischemic, then we would expect that immediately after decompression, you would see these blood vessels flowing and the patient would get recovery pretty much immediately. By contrast, if there's demyelination and that patient has had compression by the flexor retinaculum for a long time, there is a conduction block, there's demyelination, and you do the operation to improve that conduction block that's been there for so long, by 2 months, you should see recovery of function. By contrast, if it's axonal, it's that millimeter a day to go anywhere, and it's a much slower process. And in compression neuropathies, there's typically components of ischemic block, demyelinated block, as well as axonal injury. So you get this step-like type of recovery. Patients will frequently ask you, when you're going to do a decompression operation for cubital tunnel, carpal tunnel, or whatever, when can I expect to get better? And they should expect you to come up with some answer, but it could be something like, well, I know you've got an axonal component. The nerve fibers need to grow back. That'll take a long time. I can tell on, say, carpal tunnel or cubital tunnel that there's also a demyelinating issue, and that should come back at 2 months. And if there is an ischemic component, that will come back quickly. There's a fascinating paper that was published in Muscle and Nerve by Dr. Larry Robinson, and he was looking at traumatic nerve injuries and talking about the concept of this same recovery. And it's interesting that we came up with our little hatchety recovery in the same fashion, but independently as to Dr. Robertson's discussion. So you can see after the injury, then both motor and sensory loss, and then depending on conduction block, there's an uptick. Then there's axonal sprouting. Then the muscle fibers hypertrophy. They'll actually work 5 times as hard if asked to get recovery back, and then the slower axonal regeneration. Now we're getting into the electrodiagnostic studies. You may be so fortunate as to have a physician doing your studies who will give you the history, the physical examination, do the electrical studies, interpret the numbers for you, and actually even come up with something like this that says, in summary, this is a very severe axonal ulnar nerve problem. It likely is at the elbow. There's still active denervation. There's increased insertional activity, and you'll see us talk about the importance of that insertional activity being active. It's been 8 months, so that's a while outside that 3 to 6 golden month period. But I think an AIN to distal ulnar nerve transfer is still a reasonable consideration. However, more typically, this is the result you get from the electrical studies. They summarize the situation, and then they tell you that clinical correlation is advised. So it really is helpful if you know how to interpret the studies yourself in order to come up with an understanding of the type of injury, whether it's going to get better or not, importantly, whether or not the muscles are receptive for nerve reconstruction. And so here we go on the electrodiagnostic studies. There are 2 parts. There's the nerve conduction study and the electromyography. When you're looking at the nerve conduction study, there's 2 key things to look at, and one is amplitude and one is velocity. Amplitude will tell you the number of nerve fibers that are not injured, and the velocity will tell you the situation with respect to myelination. So when you look at the conduction velocity, you'll see here that the axon is wrapped with myelin, and in this cartoon, the myelin is being lost. When we're looking at amplitude, we're looking at the number of functional nerve fibers. And we'll be talking about the amplitude, the height of the amplitude, and the duration of the amplitude. But in general, amplitude tells you how many nerve fibers are functioning. Now we can combine this 2 concept of the myelin and the nerve fibers when we're talking about conduction block. Conduction block is a situation when the patient will be weak in spite of the fact that they have normal axons because of an area of loss of myelin. Now, if that area of loss of myelin is severe enough, it can actually block the function. If that conduction block localizes to a known area of nerve entrapment, like, for example, cubital tunnel, and we'll use that throughout this talk as an example, then there's something a surgeon can do to help that. We can do whatever operation is the one that you typically use to correct that situation of this conduction block, which is basically demyelination in a state of suspended animation until someone does something about that with either transposition or conservative management or decompression. Now, of course, you can get demyelination neuropathy, and we see that in patients with cubital tunnel syndrome or compression syndromes, as well as diabetes, which can give you demyelinating issues. But in those cases, the conduction block does not localize to a known area of nerve compression. So here's a nice cartoon that you can see that there are a number of axons in normals, on the normal side on the left, well myelinated, and you are doing the stimulation proximal and distal along the length of the nerve to see if there is an area of block. And on the right cartoon, there are 8 axons, and 4 of them are completely demyelinated. And we've put that section of the loss of myelin in the middle of the axon to represent, for example, loss at the elbow. If, by definition, if you see a 50% drop in the number of axons, i.e. the amplitude, then that by definition is a conduction block. If every axon is blocked, then that's a complete block. Let's look at the EMG. The EMG is broken up into insertional activities and spontaneous, and then also the motor units. So the EMG will let you know whether or not there's axonal loss when we're looking at this part of the EMG, and whether or not there is axonal connection when we're looking at the motor units. So we want to know, has there been an axonal loss? And what you'll look at is insertional activity. That is when you put the needle in the muscle and you see a response, or whether or not there's spontaneous activity of fibrillations or positive sharp waves. Now, the question we have always is, if we're going to do a nerve repair or a nerve transfer, are the muscle, the motor end plates still receptive? So here we've got a study where we're looking at the over time, and on the x-axis you can see the time going from time 0 all the way out to the 1 year, just above the time point, and then way over to the side, even longer than that. And the amplitude of the fibrillations is high, and then you're in this golden period where you will see fibrillations present until you start to get to 6 months, and then even as you pull out from 6 to 12 months, you see less and less of the fibrillation potentials there, and they're moving over time to a point where finally they're gone. So really from this study you can see how critical that window is in the first 6 months, and less as time goes on. Now you can also, when they're doing these studies, they can both see and hear the fibrillation potentials early on. If you're listening to it, it sounds like somebody's taking a cellophane bag and crinkling it. You can hear it. When you put the needle in, you can see the early increased insertional activity. And then later on, when there's fatty infiltration, you don't hear it and you don't see much. And then eventually you can be actually fibrotic, and there aren't hardly any fibs or positive sharp waves there. And you can see something that will be called SRD or CRD on the report. When you see complex repetitive discharge or C or SRD on the report, it means you're way out on the timing. Now, we will see grading of fibrillations, 1, 2, 3, 4. So of course you would think, logically, if there's 4 plus fibs, this is good news for me. And it is, if you're in that earlier or your period where we've just seen those images. But an issue to remember is that what we're being told is that there are more fibrillations with the +4 than the 1+, and by definition, the terms they use are, we're seeing persistent fibrillations widespread in a few areas, in 1 or 2 areas. However, it's not a linear correlation here. And you can see if you look at the y-axis with the amplitude, it's very small amplitude fibrillations on the left column. There is a difference between 1, 2, 3, and 4, but this image would be towards a later period of time where there's maybe 2 or 3 plus difference, but it's nothing like earlier on where you can see the y-axis there, and there's definitely a big difference between 4 plus. So that 1, 2, 3, 4 plus is helpful to know that, but understanding the idea of the importance of insertional activity is also important. So when they put the needle in, if they put it in and they hear this racket of that cellophane versus nothing much, they'll tell you that the insertional activity is normal or it's increased activity. That's what we want. Slightly increased activity, that's okay. But when they start reporting decreased insertional activity, you know that you're moving into the chronicity of this whole process. Towards the latter part of this module, we'll be talking about, in cartoon fashion, about the timing of these different beginning and ending of the fibrillations and motor units, etc. So now let's get to the concept on on the right side of your EMG, they'll be talking about the motor units. And there are normal motor units, acute motor units, and chronic motor units. So we're looking at, after an injury, acute motor units and then chronic motor units, and they just look different. When you're looking at this, if you're looking at a motor unit EDX here, and you see that they're describing the motor unit amplitude potentials as long duration, high amplitude, that's chronic. That means there's been an injury and the motor units have to just spread out and do more work, the ones that are still there. If they're talking about polys, that is code for nascents, and nascents are regeneration. They'll sometimes give you percent polys, 25%, 50%, 100%. If you see 100% polys, that is great news. It means help is on the way, because each one of those little polys, nascent units, will be able to work 5 times harder when they get organized and give you better function. So that predicts good function. Important also to understand the difference between recruitment and activation. I have to admit, it took me a few years to understand this. Activation is voluntary. They put the needle in and they tell you to please move some muscle, and you could decide you will or won't. It could be a CNS problem, like you've had a stroke so you can't, or you've got ALS and you can't. But in the traumatic injuries that we're talking about, you will see decreased activation, and that makes it hard to know whether that is physiological or not, because they aren't able to engage in this activity. And it could be from pain. It could be conversion hysterical reaction. So recruitment is physiological, and we'll talk about this later on, but recruitment tells you how many of these motor end plates are connected and how many you can recruit. So if you have hardly anything there, your recruitment is severely reduced. If you've got a lot of nerves reconnecting, then it's mildly reduced recruitment. And of course, normal recruitment is everything is there. So uninjured axons, normal MUPs, and then acute MUPs break down into 2 types, collaterally sprouting and nascents. So here we have a normal cartoon axon, and then 2 of them are injured. Early on, and I'm meaning between 3 or 4 months, if there are enough axons that have missed the hit, then they will collaterally sprout and reinnervate adjacent injured motor end plates. It's like they're moving over and babysitting. It's like a physiological nerve transfer. So the injury can be up at the brachial plexus, and you can have no biceps function, but at 3 months, several inches down from the injury, you start to see some motor units arriving. That means that uninjured adjacent axons are collaterally sprouting to innervate motor end plates in the biceps muscle. Here's a little cartoon of that. So you can see that a poor axon, one over from the left, has been injured, and there's enough adjacent normal axons, they can start to send out these little satellites and reinnervate the denervated motor end plates. So you'll see the motor unit potential normal there from the normal uninjured, and then you'll see this little blip of the satellite potential where you're getting this collateral sprouting early on. Now, back to this nascent idea. Those are axons that they're the ones that are doing the inch a month, a millimeter a day. They're the injured axons, and they will start to regenerate, and they're the ones that will eventually get to target. Hopefully, coming back to support, once the nascents get there, they'll also work 5 times as hard, but in the meantime, in these partial injuries, and these would be the favorable injuries, the axonotmetic 2 and 3, if you get these collateral sproutings in by 3 months, then you should have really good recovery. If it takes longer, you may not have enough to reach the required number for functional recovery. Here's a situation where you have a completely, every nerve is injured, and we've got a nice example at the end of this module to show you that every nerve is injured. There's nobody going to help with the collateral sprouting, and so it's slow process of the reinnervation over time. Now, eventually, both of these acute MUPs, whether they're collaterally sprouting or nascents, they will take on a morphometry of chronic MUPs, where there's longer duration, higher amplitude, because each one of these motor units is working harder and expanding their territory to basically give us the function that we need in order to have functional recovery. Let's just take a look at these two cartoons here. This is a complete transection. There's various muscles. We're seeing fibrillations, and then distal to that with recovery, we'll see motor unit potentials. In this situation, there's no recovery, complete injury, no recovery, no motor units recovering. In a mixed injury, we've got a mixed injury here, and in this situation, you can see the muscles innervated by D and E have been injured, the other muscles not, and over time, there's collateral sprouting from the muscles D and F over to help the other ones that would be denervated. And this can be a situation where you'll see this different injury pattern in something like cubital tunnel or carpal tunnel. You could imagine that the pressure on the intrinsic muscles, D and F here, for example, those fascicles sit close to the bony tunnel in the cubital tunnel, and they'll have more impact than, say, the flexor carpi ulnaris or profundus fascicles that sit farther away. So important to understand that you can have this mixed injury that I described so many years ago with different injuries to different fascicles. This is such an important paper for me. It's almost 3 decades that it was published in 1993, Tessa Gordon's group. And what she's showing us here, when you're looking at the y-axis, which is recovery from 0 to 100%, and then the x-axis, which is the number of nerve fibers that are injured. This is partially denervated. And you can see this remarkable thing that as you lose nerve fibers, you don't linearly lose function, but you just top right off the cliff when you lose 80% of the axon. So when you lose 80% of these nerve fibers, you lose function. Therefore, in order to get recovery, we only need to recover about 30% of the axons to get back up on the plateau. So on average, a single motor unit can enlarge up to 5 times the original size, resulting in the ability to compensate for up to 80% of motor neuron loss. Patients with cubital tunnel will be fine until bang, off they go off the edge. When we're doing nerve transfers, what we're trying to do is to get the patients back up onto the plateau. The work we've done on supercharge transfers really allows us to address the axonotmetic 3, the partial recovery, the variable recovery. We have nerve graft, we have nerve transfers, we have end-to-end nerve transfers and tendon transfers to look after neurotmetic injuries. The Neurapraxia and the Axonotmetic 2 favorable, they don't need any operation. But it's this Axonotmetic 3 where you can use this supercharge and decide in order to try to help to push that recovery. And then the more serious injuries, as we talked about, the other different options for nerve repair graft and nerve transfer and tendon transfer. So this is a rather, this you could spend an hour just talking about this graft right here. But basically, it's now taking not just the degree of injury and a little bit of the electrodiagnostic, but getting into when would you do what operation. Now, everybody has their own ideas on how they reconstruct nerve injuries, and these are mine. Certainly happy to share. Others would have different opinions. But basically, I'd like to just point out that one key point for me in getting good results is being aware that if there are nearby areas of nerve compression in patients with nerve injuries, you should be looking for a positional or some kind of provocative pressure, whatever sign to see if you could decompress at that point. So I have that as plus or minus. And then the supercharge is an operation that I have found increasingly helpful in just getting the assurance that on that axonotmetic 3rd degree injury, the variable injury where you don't know if it's going to be good or pretty bad, where it's just edging on that cliff, to help push it back up on that edge. So in summary then, Neurapraxia, Axonotmesis 2 and 3, and Neurotmesis 4 and 5. So Neurapraxia, the axons are fine, so there's normal amplitude. You should expect either spontaneously good recovery with correction of the demyelinating process or ischemic process, or you could help that with the decompression. The Axonotmetic 2, also favorable. You'll see your motor units coming back in early, around 3 months, and you expect slow but excellent recovery. Axonotmetic 3, this is the one that's variable. This is the one that's just ready to either stay on the plateau or fall off that cliff. And you'll see the reinnervating motor units coming in later than those early, the power of a single MUP to predict a second-degree injury. Neurotmetic injuries, fibrillations, positive sharp waves, no motor units. Time is important. 3 to 6 months is golden. You can recover. Of course, we all have patients where we've done the operation much later than that and recovered, but ideal, definitely time dependent. So let's just talk a bit about some compression neuropathy issues. And I want to dig in a little bit more into the conduction block issue. So here we have, again, those cartoons, 8 normal axons, normally myelinated. Amplitude is a surrogate for the number of axons, and it's 8. It's normal. Here we have then some slowing of conduction velocity. This could be, and again, we've staged this as though this is a cubital tunnel. So the loss of the axons are in the middle of the arm, if you will, or at the elbow. So you've got still good amplitude. They're well up on that plateau of 6 and some demyelination. You can localize now that this is at the elbow. But when you have a conduction block, then you've got 50% of the axons impacted by that. Your amplitude's now 4 in this cartoon idea. And by definition, when you're at 50% loss, then that is a conduction block. A complete conduction block is every single one of them is out. And when you stimulate above that block, you'll get no response. And I'm going to show you some examples of all of these. I'd just like to say that what we're talking about is demyelination process that surgeons can help with. And that is when it localizes to a known area of nerve compression. If the patient has a systemic demyelinating neuropathy, then we can't treat that with surgery. And we will see patients with both. We'll see diabetics with cubital tunnel, and you'll notice that they'll have slowing, say, in the forearm as well as at the elbow. But when it localizes to a known area, i.e. the forearm, the elbow, that's why they tell us look above and below, then that is really helpful to help localize. If there's slowing in the forearm, then it's going to be a systemic polyneuropathy or perhaps a Morton Gruber, and we'll talk about that in a bit too. So here's a couple of examples. And when I'm looking, I'll look first over to the velocity, and you can see that above and below there's good numbers, good velocity across the elbow 36. So this localizes this problem this patient has to cubital tunnel. The next thing I want to know is, has he lost any nerve fibers? And I'll look at amplitude, and you'll see that when they're stimulating all along the whole length of that arm, they're recording in the ADM and the FDI a good number, 11, 11, 11, ADM, 8, 8, 8 for FDI. So this is mild cubital tunnel. Even though the conduction velocity is 37, there's no block at all. No block at all. If there's a block, then when you're stimulating above the block, like axilla is actually just a little bit above the elbow, and of course above and below the elbow is the cubital tunnel, those numbers would be lower, but the numbers are straight, clean all the way down. So now look at this one, now we have a block. So again, you go over to the conduction velocity to know that it's localizing it to the elbow, above and below the elbow. The conduction velocity here is 35, similar to the one above. But now go over to the amplitude, and that will tell you whether or not there is a problem with loss of nerve fibers. And you can see the numbers are pretty good. 6.5 is on the plateau, but when you stimulate above this concerning potential for cubital tunnel, the only axons that this patient can get at is represented by the 1.3. So 1.3 is definitely less than half of 6.5. So this is by definition a conduction block. So there is a permanent conduction block at the elbow. If you can correct that with an operation at the elbow, within 2 months, this person should be better because it is demyelinating. They haven't lost the nerve fibers, they have just demyelinated at the elbow. Now, here's another one where they actually have the ulnar nerve is miserable. They've lost the ulnar nerve function and they still have a good amplitude. How can that be? So we'll look over here. So this is localizing to the elbow, but when we look at the amplitudes for the ADM and the FDI, it's terrible. It's 0.8, 0.8, 0.8, 8.3 for the FDI. Really strong number of nerve fibers there, but the patient can't get at them at all. This is very severe ulnar nerve. So why is it 8.3? Well, what you'll see your electrodiagnostic people do is they'll look then for Martin Gruber. And what they look at is they stimulate the median nerve at the elbow. They stimulate the median nerve at the elbow, and then they stimulate the median nerve at the wrist, and they're stimulating above and below where a Martin Gruber would come off. So when they stimulate the median nerve at the elbow and they read into the FDI, they get a response that is terrific, 6.3. So the majority of the axons coming in to innervate that FDI are coming from the median nerve. And that is, as we know, a Martin Gruber. And by contrast, when they stimulate the ulnar nerve at the wrist, it's 6.2, but it's distal to the Martin Gruber, which peels off, of course, more in the forearm. Now, complete conduction block. This is a gentleman with a complete a block of the wrist drop. The amplitude's not bad, but when you stimulate above the spiral groove, they get nothing. So this is a complete block. And then finally, a severe carpal tunnel. If you look at the snaps, the amplitude of the median digit is NR. Of the ulnar small digit, it's 11. So really severe carpal tunnel. And when they're stimulating at the wrist above the carpal tunnel and reading off the APB, it's 1.1. But when they stimulate distal to the carpal tunnel in the palm and read off the APB, it's 3.5. So this is a severe carpal tunnel with conduction block. All right, now I'm going to close just with this concept of the timing and all these different things that happen over time. And there's a lot here, and I'm going to build it up slowly, but basically we're going from, on the left, from the time of injury to up 12 months. If there's recovery, then you'd be starting to see recovery by 12 months with a severe injury. And if there's no recovery, of course, by 12 months, not much is happening. So let's start then just following out what happens, what we see on the electrodiagnostic studies with an nerve injury. And this will be talking about the immediate changes on the EDX, the acute changes, the subacute, and then the chronic, following along the idea of Wallerian degeneration and denervation, and then potentially collateral sprouting, and then potentially nascent units coming back, and potentially reinnervation as we move over time. Then along the bottom, we can see that you'd have normal insertional activity before an injury. You'll see increased insertional activity, lots of receptivity of those motor end plates, and then slightly increased insertional activity, then decreased insertional activity. And then if there's no reinnervation, then no insertional activity. So the first thing we would see is the CMAP amplitude would drop. And this is something that I think we're all familiar with, that the CMAP or snaps will drop, but in the first 3 days, there is still transmitter in the distal nerve, so you can stimulate the distal nerve and you will get a response. And this is important if you want to do topography on the distal nerve, or if you're trying to find small distal, for example, facial nerve branches. You'll be able to go in within those first couple of days and stimulate and find them just by stimulating, because there's still positive transmitters there. The next thing you're going to see around 10 days is this crinkling cellophane with increased insertional activities. And then around 2 to 4 weeks, you'll see the presence of fibrillations and positive sharp waves. The closer the muscle is to the injury, the sooner you'll see the fibrillations. The farther away it is, the later it will take. Now, these fibrillations may go away over time. For example, in a very mild axonotmetic injury, then you'll get that collateral sprouting, filling in the empty fibrillating motor end plates, and those fibrillations will disappear over time. By contrast, if not treated, then and no recovery, then around a year, we saw that on that nice table. Around a year, the fibrillations will stop, and you can't reinnervate. 3 months, you'll see that collateral sprouting, and if you see it at 3 months, even a single MUP, it'll predict, in my experience, very good recovery. Axonotmetic 2 recovery doesn't really need surgery. By contrast, if you don't see the MUPs till 4, then you know you're getting into a more severe axonotmetic injury where you have fewer reinnervating units, and you may be on that edge of that cliff with just that variable recovery. If you don't see motor units ever, then of course you're heading towards a neurotmetic injury. Later on, those nascent units will reach target. And then eventually, all of the units, whether they're the collateral sprouting or whether the nascents, their morphometry will change, they'll mature, they'll start expanding, working 5 times as hard, and they'll take on the morphometry of a chronic unit. Now, on the far right, you'll see that when we're looking at recruitment on the EMG, if we see mild, moderate, and severe decreased recruitment, mildly decreased recruitment is predictive of that axonotmetic 2 injury. Severely reduced recruitment, a more severe axonotmetic 3, moderately severe axonotmetic 3. So in a way, for sure, the amount of reduction in recruitment is a surrogate for the number of axons that you have recovered. Now, 3 cases and then we're done. So this is an example of collateral sprouting. And you can, read this story on your own. But at 3 months, this gentleman showed fibrillations and no motor units. So it would suggest that it's not an axonotmetic 2 injury. By contrast, at 5 months, you can see that in the deltoid and biceps, he has fibrillations, he has increased spontaneous activity, and he does have some units, isolated and discrete, but definitely some units at 5 months. So this would predict he is going to be an axonotmetic injury, a favorable injury, but the variable favorite. You don't know how good that's going to be. And he does have some polys, but this would be the patient that I would do and did a medial triceps to axillary and a double fascicular transfer in a supercharged sets procedure, going to the side to ensure that I'm banking on getting him up on that plateau for recovery. And if you don't do the end-to-side transfers, then the appropriate thing would be wait and hope that in that variable axonotmetic 3rd-degree injury, they would be okay. But when you do have the sets procedure, then that gives you the opportunity to bank towards the opportunity to get them up on that plateau. Now, here's a study that will show you the changing from nascent to chronic units. This was a patient who I was able, who presented to me, and I was able to put together her electrical studies over time. And she had a lymph node biopsy or something in her neck and lost accessory nerve function. So you can see at a 1 month out, they've done a study. This is too early to know whether there would be reinnervation, but she's definitely got an axonal injury in all 3 components of her trapezius and no innervation, only 1 month. So then they did another study at 4 months, and they're seeing a single unit in the upper trap, 100% poly. So that's good news, because those polys, well, it's just one, but it'll be able to work harder. Nothing coming into the middle and lower. So this is suggesting that this is going to be a flat-out nascent regeneration. If you're not going to do anything to help out, then you're going to have to hope that those axons will just do it on their own, because there's no collateral sprouting to give them a physiological end-to-side nerve transfer, and then no one's going to come in and do a end-to-side nerve transfer on her. So there she is at 5 months. Now she's got 3 or 4. You can see the comment on the side is 3 or 4 nascent potentials. At early on, it was 1 nascent potential. Now we've got 3 or 4 nascent potentials. We've got increased insertional activity. So the muscle wants nerves, but what it's going to have to do is just grow its own. And now here, 1.5 years out, and you can see that the insertional activity is now back to normal. It's not receptive particularly anymore. It's lost the fibrillations in the middle trap. There's still some in the lower trap, but that's 2+ does not necessarily mean a lot. It's just more than 1. And you've got 1 unit in the lower trap now, but moderately reduced. So this is an Axonotmetic 3, and it's a moderately reduced recruitment, normally activating. She's trying hard. This is a patient who now I would say you could offer, some people I would offer a SETS procedure, taking a deltoid fascicle, redundant deltoid fascicle from the upper trunk, or a redundant pectoral fascicle from the middle trunk to end side to the accessory to try to get that back up on the ledge. So finally, and we're just about done, this humeral fracture, this is a neurotmetic injury. So we're expecting 4 months, and there's no units in the EDC. And so this would be a patient who I would predict would be going towards a neurotmetic injury, and where I would be talking to them about a median nerve to radial nerve transfer or tendon transfer, depending on the patient's thoughts on that. So thank you so much for your attention, and hope that this has been helpful for you and for your patients.